Hello and welcome to HFMA Talk, the podcast for NHS Finance. I'm Lisa Robertson, a Policy and Research Manager here at the HFMA. In this episode, I'm joined by national, regional and local leaders to take us through the different perspectives from across systems. It's particularly aimed at new Integrated Care Board members, non-executive directors and governors, but will also be of interest to anyone working in or with the NHS. This episode will provide an introduction to NHS finance, starting with the current context and a discussion on the role of the Integrated Care Board, along with the Integrated Care Partnership, provider collaboratives and place. We'll then move on to how the finances flow, reporting and accountability, the non-executive director role, and also where you can find further support. To hear a longer version of the conversations on the role of the Integrated Care Board, allocations and spending, and reporting and accountability, please follow the links alongside this episode. So I want to start today by thanking all of you who have joined me today to share your thoughts and experiences, and I'll ask you to each introduce yourselves.
So I'm Peter Ridley. I'm the Deputy Chief Finance Officer for Operational Finance of NHS England National.
Hello, my name is Lee Outhwaite and I am the CFO Designate for NHS South Yorkshire, one of the new ICBs.
I'm Jonathan Webb. I'm Director of Finance at the West Yorkshire Integrated Care Board.
My name's Zoe Pietschak and I'm the Regional Director of Finance in the East of England.
So I'm Carolyn Wood, Director of Finance at North West Ambulance Service.
My name's Mark Bakewell. I'm the Deputy Director of Finance at the Cheshire and Mersey Integrated Care Board.
I'm Nikki Briggs. I'm CFO for Cambridgeshire and Peterborough ICB.
So hi, I'm Sheila Stenson, Executive Director of Finance at Kent and Medway NHS Social Care Partnership Trust.
So, Peter, before we get into the detail, can I ask you to start us off by briefly explaining the current situation in terms of the financial framework and financial position?
So I guess the financial framework for this year, so for 22-23, is it's a step back towards normality, I think is probably how I describe it. So we have been through 2 years of the pandemic where we've had to be quite pragmatic, haven't we, about the financial framework, and the key has been making sure that providers who are delivering under extraordinary circumstances have those costs they need to put in covered, so they can get on and deliver what they need to do operationally and clinically, while we just make the money work in the background. This year, as we start to move out of the pandemic, and I know we're not there yet, I know COVID isn't over, but as we start to move out of the pandemic, what we've tried to do is move back a bit to normality. And I guess what that means is starting to get back to allocation of resources based on population need, and allocating those resources out in such a way that a system can determine how best to use those resources, rather than us going directly from a kind of a national pot straight into providers, depending on what they're spending at that point in time. So the framework we've got this year starts as it should do from what are people spending at the moment. So that's where we start from. But what we're aiming to do within that is start to reduce the costs of COVID, so start to reduce the costs of the pandemic as it becomes more manageable, and recognise that move back to system allocations through what we call a convergence adjustment.
Can you just explain briefly for our listeners what the convergence adjustment is?
So what we have is we've basically got a starting point of what people are spending now, and we've got an end point, which is the national allocation formulas around the need of a local population, and therefore how much each ICB should be allocated funding to look after their population. And what we recognise is you can't really go directly from one to the other, because there's quite a big gap between those two at the moment, because of just how the costs have gone in over the pandemic. So what the convergence adjustment does is we take a national efficiency requirement we've got for all parts of the NHS, and then we make a bit of an adjustment to that efficiency requirement, start to move people towards that population-based allocation. So it will take a number of years, but what we've got is almost a glide path to get from the cost base as it is now. I'd say the other big things we're doing this year is we're aiming to allocate as much of the resource as possible to a system or to an ICB level. So the legislation is absolutely clear, isn't it, that ICBs are the key building block now, really, of the new NHS, and therefore we should allocate as much to an ICB level as possible and allow that system to determine how best to use that resource. Now, inevitably, targets don't go away, do they? We've got ambitions. We have an NHS constitution. So there are a number of things that every ICB will need to deliver. But actually, we've got a target of moving as much of the money to a system level as possible and allow that system to determine how it is then used locally. It feels like a bit of a transition year where we're starting to put in some of the key building blocks of how a financial framework will work in the future, but trying to do it in a proportionate way so we get there gradually over time.
It feels like it's quite a tricky financial year 22-23. We are operationally still recovering from COVID, aren't we? We've had a 2-year funding window for COVID, which has been quite extraordinary, which has been based on the cost of the service for understandable reasons. And as we try and shoehorn our way back into normality, we're trying to work out, aren't we, what a return to a more normal finance regime looks like for the NHS. So we've got component parts of the finance regime for 22-23. We've got core funding, which is largely based on the cost of services in 21-22, but then there's an inflationary factor built into that, there's an efficiency factor built into that, there's also a convergence factor built into that, where people are purportedly spending more or less money than their fair share should be. And in addition to that, you've got some errant complexity about an elective recovery fund, which is very sensibly trying to make sure we get funding in the right places for trying to clear elective backlog.
It would be helpful to explore a bit more some of the challenges currently faced, along with the opportunities the change in NHS architecture brings to address these. Zoe, in your experience, what are you seeing?
The changes have had a significant impact on the way that funding flows across the NHS. So I think it's helpful to know that this current financial year is a transition year between the two, so getting us back to what is more like a pre-COVID financial framework. It will be slightly different, but it will be more like that. And what we're seeing this year is a reintroduction of financial controls, the requirement for contracts again, and a reduction in additional funding, with a requirement to do more for the money that we're getting as an NHS. So from a regional perspective, that means that we're focusing on waiting lists and reducing waiting lists. So there's a lot of focus on how we can work as a region across all of our systems to be able to deliver what we need to do on that. And I think that all adds up to a key message, which is there is a significant financial challenge this year, and that's likely to continue for the next couple of years as well. The other challenge I think that we've seen over the last couple of years is in a way, quite rightly, finance has dropped off the board agenda because the board has been focused on the response to the pandemic. And actually, I think something that our non-execs need to be focused on is getting finance back on the board agenda and making sure that it's part of all conversations at board level.
Mark, did you want to add anything?
So I think the first thing to say is, you shouldn't underestimate the complexity of the regime that we all live within. The way that we have to operate annually as well, it gives some challenges. So, why can't we do certain things, multi-year settlements or multi-year, and I know that's certainly where we all hope that we're heading. But I think that lay member challenge about the way that resources are used and, the rush at the start of the year and at the end of the year to try and, spend the money wisely, etc. I think can cause some challenges. For us locally, our challenge is bringing those 9 different systems together with a whole new set of leadership arrangements and new governance models that will exist beyond that. So from a non-exec point of view, I think just making sure that settles, making sure it's operating and functioning for the first 9 to 12 months, in itself, I think will be a success to get us over the line in that. Landing the new organisation, making sure that we're making good strides in terms of that recovery and restoration of services. Hopefully, managing the money as best as possible within, the control target position that obviously we're aiming to achieve a break-even position for the 22-23. Certainly from a CCG perspective, there is a lot going on, and just I suppose at this point, just want to pass a big thanks on to everyone that's involved in that, because I know how hard everyone's working, and they're a real credit to the finance profession.
Jonathan, what do you think?
We face some really huge issues, and not just about the money. We face huge issues around waiting lists. We huge issues around workforce. We face huge issues around social care resilience, and the money situation does feel different. It feels different in 22-23 clearly than it did in the last couple of years of COVID, but it also feels more constrained and more uncertain than it did prior to COVID as well. And that, I think that's despite the narrative that says the NHS is still receiving more by way of resources than it would have done had we stuck to the long-term plan financial trajectories that existed pre-COVID. It does feel different. I think the greatest opportunity is probably reflected in the title of what the organisation is going to become. So we know that individual episodes of care can be excellent in the NHS, can be excellent in social care, but what's important is bringing together those various parties into people's lives, really. So the various elements of the health and social care system, whether it be the NHS, local authorities, voluntary community sector, carers, families, and stitching all those together in a way that makes sense for that individual and makes sense in terms of individuals' complex lives that they've got and sometimes the complex comorbidities they've got. I think we're up in the ante on partnership. We're up in the ante in terms of what we think, changing the leadership dynamic, changing the partnership focus, changing the governance, changing the statute, all those things we're doing because we think they're going to have a positive outcome on people's lives for the people that we serve.
Lee, can you share some of your insights?
I genuinely think the 2022 Health and Care Act that transcends a payment model from clinical commissioning groups paying NHS trusts to provide care in what's meant to be a competitive market and replacing that where we get representations of trusts, GPs, councils working together differently to deliver integrated care in 42 different regions with a partnership committee. That feels like quite a different model and quite a different model that should enable the level of care integration that we need as a system and as a service after perhaps an organisational architecture that's been more fragmented than it potentially needed to be.
Nikki, I know this is something you've been thinking about. Can you tell us a bit more?
The NHS has had an extraordinary ability of overcomplicating finance for many years, and I think the way forward as we look at the kind of system first approach, removing some of the complicated internal markets, there's a real opportunity for non-execs, execs, and partners across the system to look at working much more collaboratively in that partnership-based approach. So I think my key messages for non-execs on those boards is, how do you focus on the system pound, not just, and look at the priorities and not just the traditional approach of allocating it to organisations. So how do you understand value across that organisation for the whole of the population, and how do they really address health inequalities and take it seriously, not just pay kind of lip service for it?
Can you expand your point around health inequalities, please, Nikki?
Yeah, so I think there's a couple of ways, really. One that we talked about is, how do we bring the health inequalities to the front of the agenda? So when we're talking about elective recovery, when we're talking in terms of waiting lists and areas like that, how are we looking at it through a different lens? How do we look at accessing services and the services that we provide through that kind of health inequalities and population health lens? So I think there's a responsibility on every board member to try and look differently at some of those areas. I think some areas where it's been made easier is the fact that we have got budget system, particularly in capital and some other areas. So how do we look at prioritising some of those care close to home arrangements? So instead of putting another MRI on an acute hospital site, how do we provide some of the diagnostic services closer to home? I also think that there's opportunities to realign the way that we fund things. We've done something in Leicestershire around primary care, ripped up the rule book and looked at how we can use population health information and local patient need to drive how we fund, how we provide funding into organisations, rather than just the traditional approach of taking last year's activity and applying a price to it. So I think there's a real big opportunity, but it depends how brave systems and organisations want to be.
So let's talk a little bit more about the role of the Integrated Care Board and how this will feel different to the role of the CCG.
I think it's a really interesting question, and I think I'd probably stick to about 3 key points. I think, which is, first, I think that the mandate and accountability is different between CCGs and ICB. So there's a requirement for a kind of financial stewardship role across the system, including financial performance and that kind of accountability without having the direct responsibility. And it's particularly that accountability part that wasn't necessarily there in the CCGs. And I think that there's a real big leadership role that those kind of ICB roles and executive posts need to play. Second difference for me, I think, is the way that accountability is discharged is very different between the CCGs and the ICB. And I think that the ICB kind of board level are much more like a provider organisation rather than just the CCG, but it's going to be effectively less member focused and more managerially led. But obviously the third point is that board is going to be extremely different. So we're now having to manage in a in an arena and an environment where partners are on the board. And how that will work, there's shared responsibility for obviously the health of the local population, which it's how that manifests itself in a board level. And obviously there's going to be representatives on behalf of the sector, not just the organisation that they support, which I think is going to be really interesting for those partner organisations and how they play that role through, particularly when it comes to local authorities and other members that aren't used to being part of NHS boards.
I guess what each ICB is grappling with is what the four component parts of the integrated care system do and how the accountability model works. So there will be powers that will be retained by the ICB. There will be things that will be discharged by a provider collaborative, which is providers working jointly together in a way that is made more possible by the Act. There will be a place-based collaboration, which in some of the bigger ICBs who've got identified places linked to upper tier authority, there'll be a place-based collaborative. There'll be a broader health and care partnership where we bring together local government and the voluntary and social care sector. And I think in reality, everybody is currently grappling with who does what around here.
There are different tiers at which decisions can be made, and there are certain decisions that are best made at a very sort of local level, neighbourhood level, primary care network level. There are other decisions that are best made at place or at system level. There are certain things that it is more appropriate to be done at a system level, and that might be about doing things at scale. It might be about dealing with issues that have been problematic for a number of years, or it might be about sharing best practice.
Zoe, can you add to this?
I mean, there's a technical difference between the two. So ICBs or integrated care boards, there is one per system, whereas in some systems currently, before the 1st of July, there are multiple CCGs, so it'll bring those CCGs together. And there will be less GP involvement within ICBs as opposed to CCGs. And from an ICB perspective, there will be more services delegated, which it makes it very helpful to align the patient pathway. So we'll have some of the services that are currently commissioned by the region and by the national team delegated out to our ICBs and out to our systems. So it's kind of the technical side of it. I think the really big difference is the behavioural difference. So ICBs working at a system level, bringing in other partners across the system, NHS and non-NHS. So I think it's a hearts and minds behavioural piece, which is really important there. And it's about the relationships that the ICB will be able to build. The key to this is all about relationships. So it's really important part of the new legislation in that the ICS duty is break even, so that each organisation has an interest in the overall system position, not just a siloed interest in their own organisation position. Really important role of the ICB in this, I see, is that they need to understand the financial performance of each of the organisations, consolidate that up to an ICS financial performance position, but also really importantly understand the risks for each organisation and what the mitigations might be, so that if throughout the year that position goes off target, there is a process to be able to get it back on track.
And Nikki, how do you think integrated care boards and integrated care partnerships will work together?
It will be different depending which system you're in and how each system adopts it. And I have a view on all things ICB and ICP that how we set things up in the next year probably won't be what it looks like in years 4 or 5, particularly as we start to establish things like place and that kind of place-based leadership, delegation, and obviously all the provider collaboratives. So I think that everyone needs to kind of give themselves a bit of a break rather than waiting for everything to fall into place and having all of the governance arrangements ready. how do you start to work together? How do you look at those principles of partnership, which is obviously what the ICP is about, around integrating services. And I think some of it is very simply, how do we share all of the information that we've got, and I think the ICP has got an opportunity to bring that longer term focus.
Carolyn, did you want to add anything from an ambulance perspective?
So from my perspective, I see the ICB being that statutory NHS organisation within the system, with the remit to commission and secure services for the population. They'll also take advice and views from the provider and other representatives on the board and within committees of the board, whereas the ICP is where the main partnership working will happen. And that will start to bring together all sectors within the system, including social care and also, of course, the voluntary sector as well, and how all elements can work together for the needs and the direction of travel for the board. From an ambulance trust perspective, the difficulty you have is that each ICB can determine the part we play. We're recognised as a key regional provider across, from a northwest perspective, across 3 main systems, but also 2 places. But each ICB may have a different approach and therefore different views in terms of how we can play into the new arrangements. Based on the guidance out there at the moment, we're expected to be a partner of multiple ICBs, but again, we're not sure how that looks and what that will mean. What we also need to consider is how we can work with these new arrangements across the patch, because there's going to be several key meetings and forums which we need to engage with, but there's only one of us and one organisation. So it's how we can service all those meetings, making sure we've got the right representation and decision makers that can support the wider systems and the ICBs as well.
I think it is something that's going to evolve, and in some of the conversations that I've had previously around this, I think there is a concern, or has been a concern, about making sure that those 2 forums don't duplicate each other. So from an ICB board perspective, the ICB will be deciding how to spend the money to deliver the best quality health for their population. I think the ICP will be working at a more partnership strategic level to make sure that all system partners are joined together in steering where that funding is spent.
I mean, in West Yorkshire, we've actually got some experience of something that's hasn't been called an integrated care partnership, but it's something that looks and feels and sounds incredibly like an integrated care partnership. So we've had a partnership board that's met in public on a quarterly basis, probably for about 3 years now. And that partnership board has been made up of council leaders, chairs of health and wellbeing boards, council chief execs, chairs and chief execs from all the local NHS organisations, with a range of supporting bodies, voluntary community sector, Health Watch, etc. So we've had a partnership board in place that's overseen, approved, brought together the West Yorkshire strategic intentions. So that's already existed for us, and I think that strategic body has helped shape our strategy. Has certainly put some constructive challenges along the way to make sure that we do look at that broader picture around wider determinants of health, making sure we do bring in that broader picture around the sort of the inequalities that exist in our societies across a range of different factors. But it has been a very powerful and vocal voice. I think the thing that made it work was to be inclusive from the outset. So I think, start as you mean to go on, be open, be transparent, meet in public, be inclusive.
Sheila, can you add your thoughts on this?
The trust that I work in, we work across the whole of Kent and Medway, which means we've got a place around every single of our ICPs, and we've got 4 in total. So actually it's about how we get our voice heard for mental health across the system, but 4 times over in the different kind of ICPs as well, but with the ultimate aim being that we have, equal care for our patients.
Moving on to how the money flows, Mark and Sheila, can you take us through how the allocations work? what money needs to be spent on, and how contracting arrangements are used to do this?
I suppose the simplest way of putting it really is that, nationally there's an allocation formula that drives the money that comes into the NHS from the Department of Health, and obviously that's negotiated, with Treasury as part of the overall government spending. The approach then is that there is a working group, allocation group that meets regularly to agree a formula, an algorithm, a methodology of dispersing that spend across the country and into the different sectors. So again, CCGs or ICBs going forwards will receive, a share of a national pot of money based on that formula and based on that approach. The formula, obviously is really complex, understandably, but generally speaking, tries to reflect, different levels of needs, deprivation, age of the population, and lots of other factors that help then to drive the value of what allocation should be for each of those different parts, and that then flows down on an annual basis into local systems. The majority of that is pretty much tied up in existing historic sort of contract spends. There might be a little bit around the margins that sometimes is given non-recurrently, and there's a little bit of room for manoeuvre, but also keen to stress, I suppose, that often the allocation doesn't always match expenditure, and that's where the need for generating savings, so in CCG language, that's been called QUIP, so productivity and other types of savings, cash releasing in the main, and certainly on the provider side, when that money is then passed through, obviously cost improvement programs. So inevitably there's always a level of challenge to the difference between the expenditure within the system and the resources that are allocated.
Sheila, can I ask you to explain the other sources of income available and the difference between capital and revenue for our listeners?
So actually, you've got the public health kind of income. You've got, as I said, provider collaboratives, which is quite new, but that is many mental health trusts now get income that way. You've got education income, you've got research income, there's private patient income, and then there's overseas patient income as well. So there are different revenue streams depending on where you are in the providers, for example, that you might get funding from. From a capital point of view, obviously, capital is used for us to be able to invest in our assets and for us to be able to kind of, procure new IT systems, which is very, very different to what revenue is used for, which is for our kind of day-to-day running of the business that we provide. So staff costs, for example, non-pay costs. So quite different to funding sources, but quite rightly so have to be kept very separate too.
And with the expected use of pooled budgets increasing, also known as Section 75 agreements, can you explain simply for us what a pooled budget is?
Yeah, of course. The Section 75 agreement allows the NHS to work with partners to contribute, a sum of money into kind of a fund, which is then used by all of the parties that are involved to commission services, whether that be health services or whether that be social care services.
Mark, can you explain a little bit more about contracting arrangements and how they will work?
Yeah, so the contract, if you like, is between the statutory body, the organisation, so the ICB in the New World, and the relative provider or organisation that will provide the services that's been commissioned to do so. There are a range of different approaches, and obviously they are changing with the times, really. So in the last 10, 15 years, we've had more of an activity-based contracting type approach. So some people refer to it as payment by results, where for every unit of activity, there's a tariff or there's a cost attached to that unit of activity, and contracts will, in the main for NHS contracts, will change as a result of that. In the last 2 years, 3 years, we've tended, I suppose, as a system to move away from that volatility and have more what I suppose you would argue is more block contract regime, so where there's certainty and clarity of income and expenditure between different parts of the organisation. And that's certainly where, certainly we're looking to locally to help support, continuity. And you may have heard the term sort of aligned payment incentive sort of models. And that's, again, where we're trying to get the system to act appropriately and together as in achieving the outcome rather than having lots of different types of behaviour.
The other thing which would be helpful for listeners to hear about is the Elective Recovery Fund. Peter, can you explain to us what it is and how it works?
Where we are this year is there's a ring-fenced pot of funding from the government. So we do have just over £2 billion for elective recovery that's been allocated by the government. And what we've done is we have asked all systems to deliver 104% of what was their 1920 baseline for elective activity. And what the 104% is of cost-weighted activity. So taking account of the fact that one outpatient appointment is quite different from a surgical procedure, isn't it? So if we weight the elective activity, we're asking everyone to get to 104% of where they were in 1920 as we start to recover. And that is what we're asking people to do to earn what will then be a system. We have a system level allocation of elective recovery funding. We then have a system of, at a system level, if people exceed that 104%, then they have the potential to add 75% of kind of a tariff for activity over and above that level. At a provider level, then, what we've got is we've asked people to apply what's called aligned incentive contracts. And what they really do is, for elective activity, we ask systems to agree with their providers an elective activity plan and a fixed payment for the activity that they mutually agree to deliver in that year. But then over and above that level of activity, a provider would be subject to a kind of a 75% of tariff payment above that level and a 75% reduction below that level. So there's a fixed payment, but then there is flex around that fixed payment depending on the activity that's delivered for all elective activity other than follow-up outpatients. Now, the slight complication to this is we're also asking that in aggregate provide that all of the provider positions on activity sum up to what needs to happen at system level. So I know that's a bit of a complication within a system where some providers are delivering against 104% plus and some aren't. But that's broadly what we're trying to achieve, is have the funding available for people to do the extra activity they're going to do and to incentivise them to do that in a suitable way.
Let's move on to reporting and accountability. Sheila and Zoe, can you take us through the financial reporting requirements and the type of financial information the board should expect?
I think it varies depending on what organisation you're in. The key things for, any audit committee stroke board is going to be the annual accounts, the annual report, which kind of tells a story of what the trust has been delivering in year, which obviously once you finish the annual report, you append your annual accounts to. And a key part of that is the annual governance statement that's been kind of drafted by the chief exec as the ultimate accountable officer that sets out kind of, any key concerns or anything that's kind of come up during the year. If I think about what I take to my board meetings, a really kind of high level summary finance report that talks the board through where we are, which is obviously going to cover all of the basic things around how much we're spending on pay, what we're spending on non-pay, depreciation, for example, but also just tracking how we've set our budget. So what's our monthly spend against budget and what are we utilising on a kind of year-to-date basis as well. So we've got a really clear audit trail. I think the other thing that my board in particular has been interested in is what's our underlying deficit and what am I doing as a finance director to kind of reduce that, but also how are we delivering efficiencies, and them two obviously massively kind of linked together. But the efficiency ask on the NHS is really large now, so I think that's going to be even more and more prominent in board papers as we move forward.
The other thing I would say is that the ICB board should have an overview of finance throughout the year. So when they're presented with the accounts at the end of any financial year, the position shouldn't be a surprise to them at all. They should be very aware of the financial performance of the ICB, but also of the system throughout the year.
Zoe, Nikki, can you explore a bit more about understanding the system financial position?
I think it's really important part of the new legislation in that the ICS duty is break even, so that each organisation has an interest in the overall system position, not just a siloed interest in their own organisation position. The really important role of the ICB in this, I see, is that they need to understand the financial performance of each of the organisations, consolidate that up to an ICS financial performance position, but also really importantly understand the risks for each organisation and what the mitigations might be, so that if throughout the year that position goes off target, there is a process to be able to get it back on track.
What we've got to really try and avoid is becoming a regulator of partners around the system. So what you don't want to be seeing is every organisation's individual detailed finance committee performance. But what you want to, I think we've got to get to a place where we start to have system level reports. So yes, it's an understanding at organisation, but it's that real a system level. How are we spending money on the acute sector, which will include independent sector, not just one or two by provider? How are we getting benchmarks at a system level? How do we start to understand transformation elective at system level, not just for each of the the key providers around the table when it comes to spend, at workforce? What's the workforce as a whole look like across the system?
Before we come to a close, can I ask each of you what would be your top tips or takeaways, particularly for non-executive directors and lay members as they take on their new roles?
So from a national position, we don't underestimate the scale of the challenge. Systems have really stepped up in the last few months to get to what are a set of financial plans that broadly meet what we need them to do in terms of the context of the allocation for the NHS as a whole. So we've really seen systems coming together, planning together, working out how they manage risks and opportunities together. So it's a really big thank you there for where we've got to in the plans that came in on the 10th of June, because they've come an awfully long way, and I know how hard people have had to work. And it's equally important we acknowledge that we know there's a lot of risk in those plans. So people, I think, have risen to the challenge. They've said they've got every intention of meeting that challenge, but have been really clear with us what the risks are to delivery on that. And I think it's really important we know that, and it's really important that people know that we've recognised that the risk in people's plans.
Jonathan?
If it was one piece of advice, it'd probably be follow the money. Don't tell me what your priorities are. Show me your budget statement. Show me where you spend your money, and I'll tell you what your priorities are. ICBs, ICSs, organisations can have all sorts of strategic intent and all sorts of strategic priorities. But if you ask the question about where the money goes, that'll tell you what really matters for that organisation and that system. Managing a system isn't quite the same as managing an organisation. The involvement of partners around the table can sometimes cause your brain to think, surely there's a conflict of interest in there somewhere. But I think if you stand back and you go back to why are we here, what are we looking to deliver, what's the sensible decision making process, are we clear we're doing the right thing, are we clear we're working in the best interests of patients and our population? If you apply those sorts of tests, the answer will fall out.
And Sheila?
The NHS is quite complex. How we do things is very different to how the private sector do things. So actually, I think there's always that learning curve for NEDs in terms of trying to get their head around the governance and the things that we have to go through with just different regulatory bodies. But I always try to get from non-execs, their support in particular, but also encourage them to bring their experience from their different sectors they're coming from into what we're doing with them and how they can support us in terms of moving forward. I think they've always got great ideas. I think they've always got really helpful suggestions. So I really do see their role as supportive, guidance, I say constructive criticism. I really want that from them as well. But also their role is a massive part of it is assurance, isn't it? They're trying to take assurance from us in terms of what we're doing to make sure, that we are spending money and making sure that kind of value for money is important.
Carolyn?
So for a new non-exec director joining an NHS organisation, I think the way NHS finance works can be quite confusing. To suddenly realise that you've got restrictions and limits around resource levels and how much you spend on your capital, it can be quite daunting to think you aren't in control of how you spend and how much you spend. So that is one thing that I think is a key message to try and get to grips with how the finance systems and the flow of funds actually work within the sector.
And Mark?
The best ones I've worked with are certainly ones who provide constructive challenge, because that's what we need and what we want, but equally they can triangulate data and information, and it's not, again, in my world, it's not just about the finance numbers, it's about the quality, it's about the outcomes, it's about the experience and all those different things, and they have an ability really to cross-check and triangulate all those different bits and really sort of make sense of it, and provide that challenge back, as I say, to the management team to not only provide some constructive challenge but equally give alternatives. There are lots of things that still need some work on, and I suppose it's just about that level of interest, constructive challenge as described. Really, we're going to get some things wrong, I think, on this process, but that's about the relationships that you have and the honesty and the transparency of making those improvements going forward. So just really an encouragement, really, of asking the questions. Does that feel right? How can we get this better going forward?
And Nikki?
I think for me, the other key take home would be, how do we move the NHS out of the 1-year cycle way of thinking, particularly from a financial perspective? We've got that opportunity with capital, but how do we look at it more strategically from a non-exec perspective? I would like them to keep looking forward, to keep looking, not just the assurance of looking back, but actually how do we look forward? How do we manage much more longer term in terms of priorities, and how we can make some real inroads into that prevention and community regimes that we really need to do the left shift and focus on much more population health rather than just the here and now. So I don't think that board members can just sit in that assurance space. There is the having to drive what the solution is and drive the way of working and the behaviours that will support that real system focus and opportunity to work and deliver differently from a financial perspective.
Lee?
We are not going to be in a position with the maturity around ICB operation that easily allows, in the first instance, this very strict distinction between this is the executive work to be done and this is how it's assured from a non-executive director perspective. So I think there is something about being sensible about how we have that board conversation at the start to say we're all executive directors and non-executive directors going to be co-designing how this works.
Zoe?
So 2 things for me. One is to look for the opportunities. So the opportunities in terms of transformation and efficiencies aren't always about investment, they're about doing things slightly differently. So I would look at exploring that a bit, exploring it at those board discussions and those multidisciplinary discussions. And also what is incredibly helpful is that level of supportive but constructive challenge. So asking questions from a different perspective. I think it's very easy in the NHS for us to be very NHS siloed, and actually what we need to do is work as systems with our non-NHS, non-health partners. And I think being able to bring that supportive but constructive challenge and asking questions is incredibly helpful. The key to this is all about relationships. So being able to build that trusting relationship across the financial community within a system is going to be incredibly important to understand what the real position is within each of those organisations at the right time to be able to do anything if they need to.
Thanks all, some really helpful tips in there. Before we do finish, are there any practical examples of support that you have seen or would recommend for individuals, particularly non-executive directors and lay members?
It is a time of change. There are some ICBs where there may be very little change, where it's one CCG to one ICB. I just need to make sure that we support, develop, look after our staff, ensure we've got the best diversity we can within our teams. We've got the best personal development within our teams, the best team development with our teams, and people have got a strong motivation to come to work. I see the regional finance team and the regional director of finance very much sitting in the middle between systems and the national team. So there's a big part of my role is being able to understand what's happening nationally and then translate that to our systems to be able to deliver locally. And also equally important the other way, so understand what's happening in the systems and make sure from my perspective that the East of England region voice is being heard, our system voice is being heard in those national conversations, that national policy and decision making. We have some of our systems who are doing having presentations to their non-execs, their new non-execs about funding, how funding flows, allocations, and understanding NHS finance. That's happening locally, and as a region we're being involved in those, which is incredibly helpful, and we can bring a bit of the national position to that as well, which is helpful. In the East we're also pulling together a regional ICB audit chair forum
to discuss issues that they have across the systems, being able to invite myself or members of my team or other directors of finance across the region to be able to have a conversation, ask questions.
So I think, so obviously we had quite a few NEDs join us at a similar sort of time. So I think that whole kind of peer support for them is really helpful. Our trust chair is a member of a kind of small group of all the trust chairs in the patch, and they get together, and I think, you know, that's kind of helpful for them to have a discussion around each of the organisation's perspective, but where they're coming from, but also for them to understand everything across the whole system. So I think that's really good, and that's what happens from a chair perspective.
Another idea is buddying. So an existing, you know, if someone's coming into the ICB who's had experience either on a provider board previously, maybe it's about sharing some of their experiences and just guiding that little bit of buddying as well.
I'd firstly be looking to the finance committee chairs and audit chairs in each of the partner organisations to have conversations with them and to make sure that they understand the differences in remit. The relationship, as we said, between the CFO and the non-exec director is really critical, but not just the CFO for the ICB. It's worth again having the conversations with the other CFOs that are within that system. Obviously, organisations like HFMA, you know, it's not just looking out for the non-exec training events. It's really getting to understand and get into grips with particularly the changes in the financial regime. So an understanding of how the financial regime's changed this year. And I know that from a CFO perspective, we have lots of informal discussions as well as formal ones across the region. So again, how they can interact with colleagues across the region at partner systems would be, I think, really beneficial.
And Peter?
There's loads of information out there. There's loads of ways of getting more information about the technical detail or what others are doing. One is the NHS Futures website. So we've recorded a number of webinars on there about the financial framework and how it works. So if you want to know the warts and all detail of how the Elective Recovery Fund works, there's a brilliant webinar on there that goes into as much detail as anyone could ever hope to go into. So NHS Futures is a really good information resource for all things kind of guidance, policy and framework. The other thing is One NHS Finance. That is all of the NHS in England coming together to look at how we develop the financial function, how we support each other, and how we hopefully make everyone's job easier. So there's a number of elements to that, including Future Focus Finance and the National Finance Academy, which has a particular focus on careers, on helping develop people, and particularly trying to increase the representation and the opportunities for groups of staff who aren't well represented, particularly at the higher bandings. There is also the Innovation Forum, which I wanted to plug. So we are trying to gather something we do badly nationally, which is pull together things that have worked elsewhere well, or innovations people have come up with. How can we put that in one place? Other people can take those on board and run with them. So how can we have a repository of information where people can steal with pride and implement things locally that have worked elsewhere? So that's all on the One NHS Finance website. So I'm really keen that people know about that.
Thank you so much, all of you, for your input today, and I hope people have found that has been helpful in giving them an introduction to NHS finance. As I said at the beginning, the full version of the conversation on the ICB role, allocations and spending, and reporting and accountability are also available. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.